All right, good evening, everyone. So this is yet another episode of the statewide anesthesia and critical care seminars, SWACs, brought to you by the Intensive Care Society of Uganda and the Association of Anesthesiologists of Uganda, all of which are available on the social media handles as shown. This is part of our running series of webinars. The previous episodes are all recorded on our YouTube channel and can be accessed for viewing. We are handling pulmonary madness, a disease of the lung that make our game tick in the critical care environment. And we have handled a number of episodes. So quickly, we're going to the previous episode that handled pulmonary oncology, and that was last Friday, same time. And during that session, we had multiple presenters take us through some of the selected aspects of pulmonary oncology. We had Dr. Esther take us through SVC syndrome, followed by a breakdown of what to expect with lung cancer in the critical care setting by Dr. Patience Atumanya. Dr. Nicholas Kaleva took us through diagnostic radiology and helped us appreciate how malignancy and other things can present in the lung. And finally, Dr. William Orodria took us through the interventional aspects, interventional pulmonary aspects in the care of patients with lung malignancies. It was a rich session, went on for about 2.5 hours or thereabouts, and it was moderated by Dr. Cornelius and myself. Overall, the take home was something to do with cancer being a great mimic that has been quite tricky to notch sometimes because we live in a very technically dirty environment where everything is assumed to be infectious disease before we can think of other diagnoses. And so diagnoses are actually made quite late after this patient has been running through different care providers. ICU rarely sees patients with the lung malignancies, but when we do, we are mostly doing it for the complications that are resulting, as well as the post-operative care that is needed for these patients. Occasionally, we get them in for palliation, but also we know that lung malignancies may present as a background condition to an acute illness requiring ICU care, where it may pull the strings, modulating the immune response and putting the patient in a much better situation than they would be if they didn't have malignancy. So these are really the things to think about when you're in the critical care environment or when you're in the ward caring for a patient who might have a malignancy. It's key to know where the ICU can come in to help and how soon you should call the ICU. So that was it, and we recorded this and put in the YouTube channel of AAU, and you can definitely access it for further viewing. So today we're moving essentially to what we'd like to call for now the last episode of pulmonary madness, and this is episode 13. And in episode 13, we are really looking at the end of the road. So we've been discussing lung pathology, where the lung is salvageable and you're trying to treat a disease that's causing it to be dysfunctional. We've really learned quite a great deal of information on what we can do in terms of medications, in terms of rehabilitation, as well as even interventional stuff. Now we're at a point where there is nothing much more that you might be able to do for that particular lung, what is that lung segment. And so we are really discussing today on the 4th of April, the end of the road for the lung. And our presenters will be Dr. Paul Maderu, who is a radiology resident who will take us through the radiological pulse for end-stage lung disease. We shall have Dr. Bruno Serunkuma take us through the care of patients who have been prepared for surgical removal of such a lung or replacement of such a lung. And then we shall have Dr. Kabuye take us through surgical care of such patients. And finally, Dr. Jack Turiahikayo will take us through palliative care of patients with end-stage lung diseases. Dr. Cornelius and myself will be moderating as usual. And so we get to it right away. As we remember, our rules are that we should stay mute and share our questions in the chat and then raise our hands for a chance to speak when the talk is done. So right away, I would like to invite Dr. Paul Madero, the second-year radiology resident at Makerere University College of Health Sciences. He will take us through the diagnostic radiology pulse of end-stage lung disease. So over to you, Doctor. Kindly share your slides and start.
Thank you so much, Dr. Esimas. Good evening, everyone. Being introduced fairly, thank you so much. And I'm privileged to kick off this today's talk. And like he has said, we are talking end-stage lung disease. My role here is to do the radiological manifestation, look at the features which are seen on imaging. My name, like he said, is Madero Paul, and I am in my residency here too. So this is a brief of how we shall progress. We shall have a brief introduction. We'll look at the imaging investigations that are relevant at this stage of lung disease. And then we'll be interested more in the radiological features that we pick up when we do image these patients. But to start, we need to be familiar with the normal lung, because the features we are going to pick up on imaging at the end of the road are all coming from the knowledge that we know of the normal lung. So I'll put here before us two imaging modalities. Just let me pick my pointer. Okay. Sorry, I'm trying to look for my my cursor, and I'll try to use this cursor and see if we can pick up. So I have a plain chest radiograph here, and I have a CT of the chest on the right. And so what I wanted to bring out in these two is us to be familiar with the normal lung, and I'll be interested in letting us pay attention to the architecture of the lung, because this is going to be a main point in our features of end-stage lung disease. So here on the chest X-ray, the ones we are familiar with, we see a very well expanded lung bilaterally, the left and right lung, and we see these bronchosvascular markings. We have these vascular markings stemming from the hilum and fanning out to the periphery nicely and tapering towards the periphery. And you look and you see no other lesions except those vascular markings all the way to the periphery of the lung. And you look at your diaphragm bilaterally, the angles in the costophrenic and the cardiophrenic, all of them looking nice. Same thing on the CT. You see these bronchovascular markings very nicely and straight and forward and towards the periphery of the lung bilaterally, without any other irregular markings, which in future, as we discuss, we are going to see that those ones are the earlier signs that we shall pick up on imaging when we do image the end-stage lung person. Okay, so to introduce the morphological concept of end-stage lung implies pathologically and radiologically non-specific appearance. So like we'll see here, many disease processes are going to present in very many diverse appearances, radiologically and sometimes pathologically. And so they are very diffuse. So because they are very diffuse, in most cases, it's not only one part which is affected, because bilaterally we shall have infiltration of the lung parenchyma that will give us inability for this lung to function normally. And we know that the lung responds fairly in a limited and stereotyped fashion to insults, depending on which level and of injury. However, when the injury is persistent, the pathological changes telescope towards a common appearance, and that is what we are going to see as our end stage lung. At that point, then the lung cannot be able to perform its primary function, which is gaseous exchange, and surely we'll be getting towards the end of the road for this patient. So the role of imaging is to offer diagnosis. In some cases, we are able to give a diagnosis at imaging, but most times we actually do differentials because we have said the presentation and the features are sometimes not specific and we can't give a diagnosis by differentials. But very important is that imaging will correlate with other diagnostic workup and be able to come up with diagnosis, especially the lung function, the tests that we do to assess lung function. When we combine this with radiological findings, we are able to comfortably come up with a diagnosis. And again, monitoring of these patients, because I mean, end of the road does not mean the road has ended. Some patients actually live for a while, and so we need to monitor them. So fall back to imaging to be able to pick up probably some other conditions that might develop within the lung, in addition to what is primarily seen. So these are the imaging investigations that we primarily do. The first one is the chest X-ray. The usual one, the cheap and available everywhere you go, you get a chest X-ray is the first one. Our challenge with the chest X-ray is it has a limited role in the diagnosis. So you will see many things appearing the same, and you might not make out a lot of sense in them. But it is good enough to start with because even if it has a low sensitivity and specificity, still you pick information, as we shall discuss subsequently. I'll show you some of these, what it is findings mean. But if you referred to the previous radiographs that I showed us, the normal architecture, you see now in this one particularly, you have started getting disorganization in the architecture. You have so many disorganized lines in the X-ray, and they have no direction. Formerly, we had normal architecture, normal lines stemming from the hilum going out the periphery. Here you have a disorganization. So we have such an X-ray. It might not give you the particular disease, but your index of suspicion of severe interstitial lung involvement is so high when you get such an X-ray. On the right, I have a chest CT. This is the preferred. And depending on the cause of the disease, if it is interstitial, we perform a high resolution chest CT scan. If there are other causes, we might do a plain CT scan, but also in some cases where contrast is indicated, we might give contrast to be able to pick up the pathology well. So the CT is good for us to make a diagnosis and also characterize. Sometimes we are able to pick out surely which regions we are seeing in this particular patient. But like we said, performs well when we want to monitor our patients. Other investigations we can do are echocardiography, because you know that severe lung damage causes increase in the right heart pressures, and these can be easily assessed on the echocardiogram. So right heart failure can ensue because of the lung which is failing. So at this point, you might get pressures as high as 55 from the normal, which is 15 to 25, probably in the main pulmonary artery and in the right ventricle. And so when you get such pressures, it also gives you an indication of the severity of the disease. Very important, because it will determine probably how long this person, it can give information to how long this person might be able to live and survive. The other are the pulmonary function tests. These ones I've talked about, the spirometry, the diffusion and capacity measurements. These are very important because radiologically we might see on CT a lung which is looking like severely damaged, but some function is still preserved, and this patient surely can live on that function. So that's why I said that for us would depend on correlation between these other investigations and then the other imaging findings to be able to come up with a good diagnosis. FDG-PET, you can use this as well in conditions where you need to differentiate whether this lesion is malignant or this lesion is benign, and others like inflammatory or infectious conditions. You can be able to use this, and also in monitoring of our patients. So what are the features that we pick up? The end-stage lung is characterized by cystic spaces of variable size and extent throughout the lungs. And this is caused by alveolar septal dissolution. We can also have extensive lung fibrosis, which is one of the primary features that we are going to look at. We can have bronchiectasis, especially the traction one. We can have obstructive emphysema. We can have bully and other manifestations. These ones, I have picked them out because they are very important and we can easily identify them on imaging, and hence we'll look at some, not all of them. But at CT, for example, the most important manifestation is the cystic space, which is a sign of severe and irreversible. I have made this bold because this signifies the end stage lung. When the cystic spaces are predominant in the lung, this lung is very fibrotic, and we consider it as severe damage, which is irreversible. So whatever we do with the lung, we can't save this lung. It has got damaged beyond reversibility. And this can be and present as extensive fibrosis. Like I said, they can present as traction and also honeycombing. So these are the imaging, the CT and other imaging findings that we are going to discuss in our topic of end stage lung. So I'll show you images of honeycombing, but let's know what it is. It is a destruction of lung parenchyma replaced by well-defined cystic structures and typically clustered in the subpleural region. We shall see these pictures. And that occurs in the extent of established pulmonary fibrosis with destruction of lung parenchyma and loss of architecture. I keep referring to architecture because once that is lost, it means we are dealing with loss of our secondary lobules, which are the primary unit of our gaseous exchange. And this means that the lung can no longer perform its role of gaseous exchange. So I'll draw attention to these images. On the left, I've put many presentations of things which look like cysts. I want to here is lung honeycombing, which are these cysts. These are cysts which are variable sized. They are connected together. The word honeycombing comes from this appearance of the honeybee combs. They are all connected together and they are as a mesh. So in our lung, in the end stage, we'll have these cystic spaces replacing the normal lung parenchyma. And so when we have that, then we are sure this lung is towards the end of the road. Okay, bronchiectasis is a term that describes irreversible dilatation of the distal non-cartilaginous airways. And it's also irreversible. Once they are so dilated, that means they can never go back to their original function. And like I said, usually, these are associated with fibrosis. Fibrosis is thickening, irreversible thickening of the intralobular and interlobular septi, which can be very coarse, can be fine or mixed, depending on the disease condition in question. So this is what we see in lung fibrosis. We can draw attention to the right. This is a normal bronchioles coming from the bronchus. When they are diseased, they get dilated. So from normal, the bronchioles dilate out of proportion. So we can have cylindrical dilatation where they are smoothly dilated without any changes in the outline. But we can have other forms where our interest today is, which are varicose and then the cystic, especially the cystic. The bronchioles dilate out of proportion and form those cystic structures. And this can no longer perform the function of gaseous exchange, and they can transmit air. An example is here. We have on image A, we have this bronchus with these dilated, severely dilated, with these margins pulled out, and it is coarse. So you see, it is not as smooth as the normal bronchiole or bronchus can be. So this is traction. They are pulled apart because of extensive fibrosis that is happening in the lung parenchyma. On the left here, on the right here, we see image B has the whole lung has many areas of cystic changes. So the bronchioles have been dilated. They are so dilated, and they have lost their normal outline. They have become cystic, and they can no longer perform their function. So at this stage, if the disease is so diffuse, then we will say this is towards the end of the road for that lung, particular lung. And so there are several conditions, like we have said, that can present like that. And we are going to look at a few of them. I've listed a few here. For example, the idiopathic pulmonary fibrosis, which we'll look at it as usual interstitial pneumonia, because we can't diagnose this on radiology, but we can look at the pattern and suggest it is there. Then we can have fibrotic hypersensitivity pneumonitis. We can have fibrotic sarcoidosis and silicosis, also fibrotic non-specific interstitial pneumonia. All these are interstitial lung diseases, but you can have post-primary pulmonary tuberculosis when the lung is damaged beyond normal, and you get fibrosis from this post-primary TB. But you can also have malignancies, giving you destructive features that will cause appearance of the lung in the manner we have described. Not forgetting COPD. You are thinking of emphysema and the other causes of COPD. All these can be picked up on imaging, and in this state, we know the lung is surely irreversibly damaged. So most of these patients will come with progressively worsening symptoms. And it's not a yesterday thing that keeps coming slowly by slowly. So they have shortness of breath, they have fatigue, they have reduced ability to perform daily activities, and so many things. And the patient surely is headed to the end of their road. So let's look at one by one in a few minutes. And first, we look at the UIP. We call it usual interstitial pneumonia. And we have, this one is diffuse. Everywhere you will see these findings that we want to mention. We say that honeycombing is usually basal and subpleural in predilection. And so the distribution is such that the cystic structures are in the subpleural areas. If you look at this chest X-ray, there will be so many here, and then they will be in the subpleural areas. And if you look at this X-ray, they are diffuse. You can pick them actually. When you look critically, you see so many cystic areas in this lung, and also in this lung, basal and subpleural. But look at the architecture. It is lost. So many cross-bracing wires everywhere. This is fibrosis, extensive fibrosis, and this lung can no longer perform its primary role. On CT, of course, this is where we pick most of the findings. We say that it is subpleural. So you see it is honeycombing. So we have these cystic, variable sized cysts, and they are connected. They are like layers stuck together, one over the other, and they are subpleural and basal areas all over the lung. Once this happens, then these are features that can tell us that this lung is severely damaged and surely might not salvage it. The other is fibrotic hypersensitivity pneumonitis. We know it as a chronic, non-progressive fibrosis, often progressive, fibrosing form of interstitial lung disease, and it's caused by inhalation of antigens. So the lung, in response, there is the response is like hyperreactivity 1, and the lung instead destroys its own structures. The body destroys its own structures in a bid to rectify the problem of the antigens. So you can look at this lung, different from what we have seen. We see these cystic areas, which are not only subpleural in the setting, they are almost spread everywhere, okay? And you don't seem to see the subpleural and basal redirection of the cystic changes. So this is why I said that at imaging, we can be able to direct the diagnosis to say this is UIP, for example, and it is not hypersensitivity pneumonitis, but also in combination with the history and examination findings, we'll be able to definitively point to a particular diagnosis at imaging. We see the same condition with widespread lesions all over the lung parenchyma. To note in this image, for example, you have what we call a 3-density pattern. You have these areas of lucency, hyperlucency. This is not normal. This is trapped air, but you have these areas here, which is the normal lung. And then you have areas of ground glass opacification. So the difference here between the UIP, the usual interstitial pneumonia, and this hypersensitivity pneumonitis is that you will have ground glass appearance in the lung, and then you will have other densities. So a 3-density pattern will point more to a fibrotic hypersensitivity pneumonitis than usual interstitial pneumonia, hence making up a diagnosis. The other that we can look at is a fibrotic sarcoidosis. We know that this one is the cause is not known, but we present with nodules, which because of the body's defense mechanism, they become granulomas. Okay, and these granulomas can be surrounded by fibroblastic foci with variable degree of volume. So we have so many all over the lung, these these granulomas spread all over the lung. We see where the arrows are pointing. And around those, you have volume loss. You have no lung, no normal lung in those areas. So imagine that has happened to all the lobes of the lungs bilaterally. Then that means we have just a lot of fibrosis. We have those cystic changes, and we have no normal lungs. So the patient in this case cannot be able to get enough air as needed. The other we'll look at is fibrotic non-specific interstitial pneumonia, which is a subtype of the non-specific interstitial pneumonitis. It's one of the most common ones and manifests as a chronic interstitial inflammation, which is obscured by interstitial fibrosis. Again, different from the other setting, here we have a bibacillar symmetric ground glass opacities with reticulation and traction bronchoectasis. So we see that we have bronchioles which are dilated, but they are not, their walls are not smooth. They are irregular. They are tracting. They are being pulled apart by the fibrotic tissue from the septum. And we have variable areas in the lung parenchyma which are like that. So if this condition is diffuse and bilateral in both lungs and affecting all lobes, surely this patient will be headed to the end of their road. And I think finally, look at post-primary pulmonary tuberculosis. And we know that this condition is predominant in the upper zone. So in this CT that I put on the right, we see there are areas of patchy consolidation and cavitation in the upper lobes bilaterally. If this condition affects, we know that it affects upper lobes, but this can progress to the lower areas as well. like you see now, this lung is struggling, these bronchioles are dilating, and they are very irregular. So there's fibrosis. First of all, the septi are thickened, and they are pulling against the bronchioles, and so there's traction bronchiectasis. So in this case, if this affects all the lobes and the patient has no normal function, then this is one of the features that will know the lung is surely gone. So we know that the healing of post-primary TB has fibrocalcific areas, so we shall pick up those fibrous and then calcific areas. But we also have bronchial stenosis because of the fibroblastic calcific areas. We will have lobar collapse, volume loss, because the primary lung, the secondary lobules are destroyed, so we have destruction of the lung, so the lung collapses, and we have traction and then impaction in the bronchioles and the bronchi as a manifestation of this disease. So what do we want to understand from this talk is that the end-stage lung disease is a progressive and irreversible damage of the lungs. So at this point, however much you treat pharmacologically, you might not get results. And imaging plays a role in the diagnosis, differentials, and monitoring of these patients. But very important is that to manage this patient requires a multidisciplinary approach where we do imaging and correlate these with pulmonology findings and interventions and all that to be able to come up with good end of life for the patient. So some patients will benefit from lung transplantation. Of course, that will depend on the criteria, because not every patient will benefit from that intervention. However, if we don't have an option to the patient, we can't transplant, then we provide the best end-of-life care that can be afforded, and we help the patient make their good wishes towards the end of the road. I thank you so much.
Excellent. Thank you so much, Paul, for that brilliant presentation. All right, so I haven't seen any questions on the chat. I'm hoping that people are quite impressed and quite educated. That's why there are no questions. But in case there's any question, a burning question, please raise your hand so we can let you fire away. But maybe in the meantime, Paul, one of the things that came out of your talk is the relationship between the cardiovascular system and the lung. And so as lung disease progresses, it appears to have a trophic effect, certainly, on the right side of the heart as well, which progressively dies and fails. What clues would you be looking at on the radiograph to suggest that, you know, that right heart, or at least the pulmonary circulation, is quite messed up as well in the same setting?
Okay, thank you. So on the chest radiograph, we will be looking at one, if we have right heart failure, we have when the lung fails, then the right heart fails. So we'll have dilatation of the right heart border on the chest radiograph. So this border here, which is neatly here, will be dilated out of proportion. Okay, and then the left ventricle, of course, will dilate. We don't see it evidently here, but this is what will happen when the ventricle is dilated. You'll have, the right ventricle, sorry, you'll have displacement of this apex superiorly. So it will be, the heart might dilate also, enlarge to the left, but this apex will be elevated, showing us that our right ventricle, which is right here, is dilated. But in the lung, for example, you would obviously see the pathology if there is a If there is fibrosis, if there is traction, bronchitis and combing, you will definitely see the pathologies. I have mentioned them earlier, but those on the heart will be such that the heart will dilate, will enlarge, and then you have those features I've mentioned.
All right, thank you very, very much, Doctor. So thank you very much. You used your time quite very well. If there are any questions to arise, kindly put them on the chat, and then Doctor will respond to them there. So right away, I would like to proceed to introduce our next speaker.
Thank you so much, Erasmus. And I just wanted to make mention of one of my mentors who is joined the call, not usually coming, but Dr. Mbaba has joined us and is very much biased in the topic of pulmonary disease. Just to say thank you so much for joining.
Thank you so much, and please deliver our deepest gratitude to the department. Dr. Rem, Dr. Fiona, they've been coordinating this and helping bring a big, team of people to help us cover a lot of material. And this has made it quite fun. So thank you very much, Dr. Paul and Dr. Mbabazi, for being on the call and also for your participation today. All right, so I would like to introduce our next speaker. So once a patient arrives in end-stage lung situation, one of the interventions we might choose to do is to remove that part of the lung if it's possible, do a pneumonectomy or do a lobectomy. Some patients are lucky to also have a matching donor who probably donate the lung or maybe a heart and lung in case they are the lucky kind. So Dr. Bruno Serunkuma, who's a fellow in training in cardiothoracic anesthesia at Uganda Heart Institute, will take us through the care of a patient with end-stage lung disease who is undergoing these interventions. Over to you, Doctor. Okay, as Dr. Serunkuma shares, we've got a contribution from Dr. Mbabazi regarding the signs of pulmonary artery hypertension on CT. Says the diameter of the main pulmonary artery is larger than the ascending aorta at the same level on the chest X-ray, and the hilar vessels will also be enlarged. Yeah, so kindly just note that, and guys, add that to your X-ray reading skills. I know CT is here now, but we've always been the kings of chest X-rays. All right, thank you so much, Dr. Mbabazi. Dr. Serunkuma, are you okay? Dr. Bruno, you're still muted. You're still muted, Doctor.
Okay. Sure, you can see my slides.
Yes, you can see your slides and you can hear you as well.
Okay, fine. Thank you, Dr. Erasmus, for that kind introduction. My role today is to present to you how these patients are prepared. That is the pneumonectomy patient and the patient who's going for heart-lung transplant. So this will be a course outline, which we're going to see. We shall define what pneumonectomy is. I shall also look at indications and contraindications for pneumonectomy, how we prepare these patients who are to undergo pneumonectomy, and then what are some of the changes these patients go through after having undergone pneumonectomy. And then lastly, we shall look at how we prepare the heart-lung transplant patients and also the complications associated or post-lung transplant. So there I try to, in the picture on your left, just try to show different lobes of the lungs. And you realize the right lung has 3 lobes and the left lung has 2 lobes. For a pneumonectomy, you realize that the entire lung is resected out. And on the picture on your right, still it just try to demarcate different segments in the lung and different fissures. And this pictorial is just to take us through this slide. That apart from the pneumonectomy, there are other things which can still be done. For example, pneumonectomy, as I said, that the entire lung is resected out. For lobectomy, 1 or 2 more lungs, one or 2 more lobes of the lung is removed or resected. For a segmentectomy, a portion of the segment of the lung is resected. For a sleeve resection, a lobe or a major bronchus of the lung is resected. For wedge resection, only a portion of the lung that contains a tumor is resected. When it comes to indications of pneumonectomy, they are grouped into 2 majorly. There are those which are malignant indications, and there are those which are non-malignant indications. The malignant one, the lung cancer, especially the non-small cell carcinoma, which almost the very most common one, almost 80 to 85% of these patients who present for a pneumonectomy have at least that specific cancer, the adenocarcinomas, the squamous cell carcinoma. So you realize that a tumor may be centrally located, or it may be sorry, we are still talking about the indications of pneumonectomy. I was talking about the malignant causes. Lung cancer is one of the most common cause of pneumonectomy, and I was talking about the most common type of lung cancer, which is non-small cell carcinomas, which is the very most common cause of the pneumonectomy. So I was still saying that you may find that the tumor is centrally located or may involve multiple lobes. So when the tumor is really centrally located, you can't really resect, for example, the middle lobe, if it is a right lung. So you are going to be forced to resect entire lung. For the non-malignant causes, majorly 2, we have those which are traumatic. For example, in traumatic lung disease, where you have a blunt or penetrating trauma, which involves injury to the major tracheobronchial tree. So this is usually an emergency, and you are really going to get in as fast as you can to resect out that lung to save your patient. For non-traumatic one, for example, the severe inflammatory lung disease, the idiopathic pulmonary fibrosis, sarcoidosis, and connective tissue disease, which are usually associated with the lung. Coming to contraindications of pneumonectomy, advanced age. So these patients usually are going to present with, first of all, a lot of multiple comorbidities, and also I realize that their reserve is really very small or very reduced. So these are patients whom you may not really consider taking for pneumonectomy. Reduced pulmonary function tests. Dr. Madilo talked about the different pulmonary function tests which we usually do. The spirometry, where we usually assess the forced expiratory volume in 1 second, and also Another function test, for example, the diffusion capacity of the lungs for carbon dioxide. So these are usually very key, even in assessing the mortality and morbidity post the resection, and also they're also a marker of the remaining reserve of the lung you're having. So there are some cutoffs. If at all the functional, the forced expiratory volume in 1 second is less than 30% in this patient. This is not a patient whom you may consider taking for pneumonectomy. And you may still maybe cancel these patients for maybe palliation and other things. So need for a right-sided pneumonectomy is one of the contraindication, though not absolute. So why right-sided pneumonectomy is really not advisable? Because looking at anatomy of these lungs, of the right lung, you realize that first of all, it has 3 lobes. It contributes the biggest percentage of the patient's pulmonary function, and also the complexity of the lung. It's also associated with the complexity of surgery. The blood vessels associated, which are feeding these lungs, and also post pneumonectomy, we shall see most of the complications as a result of right-sided pneumonectomy. So you may have to think twice if you have to do a right-sided pneumonectomy, because the complications post-surgery really very bad. If a patient also have severe valvular disease, significant pulmonary hypertension, or poor ventricular function, such a patient may be considered for maybe lung transplant, as we shall see, because removing one lung may not be the solution. Because we shall see the interaction of the cardiovascular system and the respiratory system. So if a patient at this stage, you would really recommend this patient either to go for palliation or to do a transplant, but not a pneumonectomy. What do we have to prepare for this patient? So remember, the goal is one, we have to evaluate this patient. A number of things which we have to do, because most of them, they have multiple comorbidities. They're a bit elderly. Also, we have to do risk stratification for this patient. Medical optimization is also key, so that to ensure the best outcome of these surgical procedures. So one thing which I've already talked about, the pulmonary function test, spirometry, where we have to see the forced expiratory volume in 1 second, is very key, because the results of this test is going to give you a clue of what the remaining lung is. Lung volumes, lung volume measurements, and the diffusion capacity of the lungs for carbon dioxide is also very key. So in fact, this is one of the very first thing which you have to do before assessing this patient. Secondly, you have to manage the chronic condition which these patients have come with. Most of them have a chronic obstructive lung disease. You have to optimize them. Hypertension, you make sure that the blood pressures are within the at least acceptable ranges. For those diabetic, you have to control the sugars. Most of these patients are smokers and have been chronically smoking, and we know the issue of smoking with anesthesia. Remember, there are mostly 2 components of smoke, that is nicotine and carbon monoxide. But also you have to remember that what nicotine does to your the mucociliary structure in your airway, that they're really going to impair that ciliary motion. in your airway, and also they are going to make your mucus very very thick, which is going to be retained deep in your airway. So issues of hypoxemia post-surgery in these patients is very key. So at least optimizing these patients who have been smokers at least 1 to 6, 4 weeks to 6 weeks is key, as most of these, for example, new structures are trying to epithelialize, and also the carbon monoxide, which has a very high affinity for your hemoglobin, at least to have less accumulation of this in your body. So this patient have to at least be rehabilitated and their surgery be rescheduled. Given the bad outcomes of which we usually have in these patients or to smoke. So comprehensive informed consent is very key, because the surgery itself is very invasive, and also prepare the patient and the relatives for post-operative complications. Routine laboratory investigation is also very key, and also you have to assess the functional capacity and cardiac risk assessment, which will involve the electrocardiogram, the ECG, and also stress test. As we shall see, that most you may have the primary disorder, which being the lungs, but also the heart is very affected. So assessing the lungs, we should not forget to assess the cardiac function. The recent imaging is very key, because this is really going to mark or guide the surgeons as they do their resections, and the medications which the patients have been on. So you find that maybe patient is having an active infection, you have to treat them. And also you may have to start patients on bronchodilators before surgery is considered. You see the COPD patients. So you need at least optimize these patients before scheduling them for surgery. Intraoperatively, what should we prepare for these patients? Thoracic epidural catheters should be placed in preparative phase, so that you have to properly control the pain. Additional regional techniques, paravertebral blocks and intercostal blocks have to be also sought for, so that you can properly control the pain. Invasive monitoring is very key, central lines and then arterial line monitoring, because the surgery, first of all, is very complicated, and also you may find that also you may have underlying cardiovascular function, and you may have to titrate your drugs accordingly. Usually you do single lung ventilation, which is usually achieved via double lumen endotracheal tube, or a bronchial blocker, which is usually this one usually you may use bronchoscopy to guide the placement. Transesophageal echocardiography is very key, because you may need to still assess the cardiac function intraoperatively, because the cardiac function may really not be good, and also may also guide the choice of either inotrope or vasopressor, which you may have to put. And also pulmonary artery catheters, these will also have to measure, for example, pulmonary artery wedge pressures and pressures in the lungs. This also will be very key. Positioning is very key. Usually these patients are positioned in the lateral decubitus position, and pressure points must be really very padded, because you want to avoid the nerve injuries, given the surgery usually takes longer. It comes to fluid resuscitation, restrictive IV fluid strategy must be employed, because these are not patients whom you're going really to load or do your Libro fluid management with, because one of the risk of or complication in these patients is post-pneumonectomy pulmonary edema. So when it comes to hemodynamic instability, for example, with ongoing blood losses, at least you have to do restrictive IV therapy, or you may have to start your inotropes. Arterial blood gases should be run because you really want to assess adequate oxygenation and ventilation of this patient, because you're almost working with one lung and you want to achieve the best of all. So most times these patients extubated on table or maybe shortly after the surgery because of course the positive intrathoracic pressure or the positive mechanical ventilation may really worsen or may predispose this patient to a number of complications. For example, those fistula, the fistula. So extubation is key if you have to extubate this patient, such that you try to minimize post-operative complications. Post-operative phase, usually the goal is to minimize complications, and you may have still to continue with these things which have already started intraoperatively. Invasive monitoring, oxygen should be controlled, fluid management, as we say, should be restrictive. Pain management, and then also radiodietary progression to this patient is also very key in post-operative phase. Immediate post-pneumonectomy patients are usually going to face a number of complications. So initial changes which these patients are going to have air filling. So in that space, in post-pneumonectomy space, one of the things which are going to fill in that space is air, and should be monitored, and should be monitored very well. Of course, just do POCAs, chest X-rays must be done, because find that some patients have not been extubated and you have air leak. So air leak, which will give you those fistulas, should monitor these patients. And then fluid accumulation still in that space is key. Sometimes can be fluid or can be blood. So monitoring should be done. Mediastinal shift, yes, mediastinal shift. So because you've removed one lung, so you may have the other side or contralateral side having, of course, tracheal deviation and everything, which is going to impact on other organs, for example, the heart. The diaphragmatic elevation and hyperinflation of the remaining lung should also be monitored for. This is just a chest radiograph finding for an immediate pneumonectomy. So realize that your left lung has been removed, and there is fluid can really accumulate. So you can see fluid level as high as this. So this is really fluid accumulation. Not sure, could be blood or maybe really fluid. So should be monitored well. We have long-term changes. You can have shrinkage of that space, post-pneumonectomy space. Of course, as we say, that can be fluid, can be pus, can be air. So this still may necessitate. So you realize that, as I think the surgeon will really elaborate on that, that unlike other thoracic surgeries, you may not really rush putting a chest tube or leaving a chest drain in this patient, because as we're going to see in the next slide, that most of the organs, for example, the heart, you're at risk of injuring them. The heart may herniate and then gets into that post-pneumonectomy space. So should be support, but of course under very good guidance. So you see the pictorial on your left. The heart has herniated into that space, the postpneumonectomy space. So if you are to put, for example, a chest tube, you may injure or puncture heart chambers. So usually blind chest tube insertions are really not recommended in these patients because of risk of injuring the heart organs. And then on your right, you see the liver. The livers occupy the space where the previous lung has been resected. So if you are to insert the chest drains post-operatively, you are at risk of injuring them. So usually, if they are to be inserted, should be really under guidance and with mind of injuring those organs. So these are some of the complications. As we already talked about, the postpneumonectomy syndrome, usually as a result of accumulation of air, fluid, and everything. So these may really compress. There is a compression which can happen on your tracheobronchial tree and then cause things like, for example, stridor. You're going to have difficulty in breathing. Patients going to get into respiratory distress. So all patients, what I didn't really point out, all patients post-pneumonectomy must be under ICU care because all these complications really, the ward cannot really manage them. Bronchopleural fistula, this one I've already talked about, but of course, you have air leak into that space. So air may really accumulate and then, of course, cause compression of organs. So especially becomes very worse if a patient is under mechanical ventilation. So that's why it is advised, if at all you can do early extubation of this patient is very key. Post-pneumonectomy pulmonary edema, I've talked about it. Usually it's worsened by majorly when you do libero fluid resuscitation, or even you have capillary leak post-surgery, can also worsen this. So it is ideal a patient to be given a steroid to try to minimize this post-operatively, but also forms of hypotension, which I've already alluded to, that this patient must have restrictive fluid resuscitation. And then also you may consider inotrope or vasopressors. Primary complications, also key, and also arrhythmias, the AFib in these patients is key and should be monitored for post-pneumonectomy cardiac herniation. As I showed you in the previous picture, that the heart may assume the post-pneumonectomy space, and things like chest tube insertions may really injure your lungs. The cardiac chambers. Injury to the surrounding organs, spleen, liver, is also one of the complications. It comes to postoperative lung function. So most of these patients, because you've resected an entire lung, so you do not really expect the baseline function of this patient, of their lungs, to be the same. So you realize that, of course, the function is going to be decreased, which can be even predicted before the pneumonectomy. Your post-expiratory volume in 1 second, it can reduce as less as 50%. And then also your diffusion capacity for carbon dioxide can also be reduced. And also the compliance of these lungs and airway resistance is really very high. So for someone taking care of these patients, in ICU, you have to put into consideration of all these things. And then if your patient is under mechanical ventilation, your settings on mechanical ventilator should not be as if somebody has two lungs. So you have to put that into considerations. This is just a summary of the complications which we've just talked about. I think we've talked about most of them. Lastly, we shall talk about lung transplant patients. We have to put into consideration that for these two organs to fail and somebody to require a heart-lung transplant, the three things could or must have been in place. One, you may have a primary cardiac lesion, which is going to lead to primary failure, as we are going to see. For example, you may have a congenital heart defect. For instance, it can be a ventricular septal defect, atrial septal defect. If at all there is delay in the correction of this defect, it's going to lead to things like increased pulmonary pressures, pulmonary hypertension, and Eisenmenger syndrome. We're going to see how that really happens. Or you may have a primary pulmonary disease, which is leading to cardiac failure. Or you may have a systemic process, which is causing both cardiac and pulmonary failure. What are some of the indications of heart-lung transplant? So you realize from the presentation of the previous speaker, he has told you that you may have, for example, especially a patient who's really on the end stage heart disease, lung disease, that it may necessitate either you doing a pneumonectomy or coming to either to do an isolate lung transplant. So, however, so we see the association, the relationship between these two organs. For example, in our first indication, in fact, this is one of the most common indication of heart lung transplant, the congenital cardiac malformation, giving you Eisenmenger syndrome. This is one of the most common cause. So now Eisenmenger syndrome is usually a complication. Usually it's a long-term complication as a result of delayed correction of a congenital defect, which is going to result into elevated pulmonary pressures and also a reversal of the shunt. There's some, the next slide we are going to see that and then really appreciate well. So usually the secondary pulmonary disease may become really unsalvageable, especially when the pulmonary, the pressures usually greater than 3 to 5 Wood units. You may, even if when you use which modes really, or inotropes or what, you may not really hope the failing heart. And there is one note here that when a heart transplant alone is performed in the face of such high resistance, there is a risk of acute right heart failure. So this patient must be, first of all, assessed well, because the relationship of these two organs, that if one fails, it's going to result into the other one failing. So if you consider, for example, an isolate organ transplant, and without considering the counterpart, so your patient may really struggle so much post-surgery. So this pictorial tries to show us how really Eisenmenger syndrome develops. So you have a congenital heart defect. Can be atrial septal defect or ventricular septal defect or a PDA. So I just dive down here. I will just take one route. I'll take, for example, atrial septal defect. So with atrial septal defect, one thing which you have to appreciate that you have relative compliance at the right ventricular side. So you're going to have the right ventricle receiving most of the volume from the left side of the heart. So you're going to have increased RV filling. When you have an increased RV filling, you're going to have an increase in the right ventricular end diastolic volume and the pressures in the right ventricle. As a result, you're going to have increased pressures, as I said. So you're going to have your RV hypertrophying. When it hypertrophies, that means the pressures in RV, remember RV really is not designed to receive or to contain pressures. So RV pressure is going to outweigh that of the LV, and then you're going to have a shunt reversal. Previously, remember these are left-right shunts. So at the terminal ends, you're going to have your shunt reversing from left to right to left. Hence, you're going to have Esen-Menger syndrome. Then the other side, because you have increased RV feeding, you're going to have increased pulmonary blood flow, giving you pulmonary edema, pressures in the lungs really increase, then pulmonary hypertension comes up. So you see the relationship between these two organs, the lungs and the heart. So the patient, for example, really at the stage of Esen-Menger syndrome, so you have to consider two things. Of course, the lungs have failed, the heart has failed, you cannot really do anything. The only thing which can really maybe save this patient is the heart-lung transplant. Then the second indication of heart-lung transplant, when you have a primary pulmonary hypertension disorders causing right heart failure. So we've already seen things like, for example, pulmonary fibrosis, which the previous speaker has already alluded to. So with increased pressures in the lungs, of course, the RV is going to fail. It's going to be pumping against very high resistance. As a result, you're going to have your right hearts failing. So you may still consider heart-lung transplant in these patients. But I have to put one point that, of course, before considering the patient for this particular type of transplant, you must have maximized the medical options. That means that heart-lung transplant will be the last resort. Then the third indication of heart-lung transplant, patients with systemic disease, which causes both cardiac and pulmonary failure, for example, cystic fibrosis, which is going really to affect your lungs and the heart. So you will still consider heart-lung transplantation. These are some of the contraindications of this. So active malignancy or history of malignancy in the last 2 years, of 2 to 5 years, you may not still consider such a patient. Active substance use disorder, uncontrolled psychiatric disorder, and then non-compliant patients. Poor social support, this you may still not consider doing heart-lung transplant. And then blood group incompatibility of the two parties, the donor and the recipient, still you will not proceed transplanting this heart. These are some of the things still which you have to do preparing this patient. Similarly to what we saw in the pneumonectomy, most of the things are really the same. Intraoperative, still you will consider most of the things which we talked about, and you have to prepare for really the worst and for the worst of this patient. Your defib, all forms of inotropes, vasopressors, you prepare for this. And then also one thing which you have to know that all this must be done. This is not usual the usual surgery. This surgery must be done on cardiopulmonary bypass machine. These are some of the complications post a heart lung transplant. I just highlighted isolated complication for lung transplant. In fact, both of them, one of the most common complication is rejection, hypertrophy rejection. In fact, the most common cause of death in these patients, early and also can be late, rejection. Rejection in early 24 hours, you realize you have a hemothorax, effusion, empyema, air leak. All these must be looked for and closely monitor this patient for all these complications. Then lastly, for cardiac transplant, still the major point here is rejection. That's what really kills this patient in post-operative phase. Thank you very much. Back to Dr. Erasmus.
All right, thank you, Bruno. Lovely talk. Thank you so much. It was quite a broad topic, and I'm glad you hit it in such a period. So to generate some questions on the chat already. First question from Lydia Candy is, can you perform CPR on a patient who has had a pneumonectomy? And what is the percentage having successful return after CPR? Maybe you can respond to that, Doctor.
Thank you very much, Dr. Erasmus. I would really not do CPR on this patient because you have one lung and the risk of all these complications, as we've really tried to allude to, they're going really to multiply as, I think, as high as possible. But this kind of a patient whom I would, in preparative phase, we discuss things like maybe do not resuscitate, because I think resuscitating them may be very futile to the team and the patient. I don't know what you say about that, Dr. Erasmus. And then really getting risk. Not sure, because I think I've not taken care of one patient. I'll seek some guidance from Dr. Erasmus to elaborate more on this point.
Sure, thank you. Yeah, so this is quite an interesting question, and yeah, nicely framed by Lydia. So yeah, in the immediate post-operative period, surely it's one of those Tarantino moments when these patients, probably get a cardiac arrest or get some sort of horrible cardiovascular instability that needs emergency response. And usually these patients are kept in the surgical unit, the thoracic surgical unit, where the team is aware of their issues and the possibilities. There's an algorithm for diagnostics and intervention. For example, if the patient were to bleed, to get maybe a hemothorax, maybe a pneumothorax, there are interventions to perform alongside the rest of the care. So for sure, chest compression could be a possibility, but the biggest goal I've noticed from most cardiosurgical teams, I'm hoping the next speaker will give us a bit more detail on it. What most cardiac surgical teams do is an early thoracotomy. So in that case, they usually have wire cutters, so they can actually open up that chest and do a direct cardiac massage where necessary, and also address the primary issue, because these chests tend to be quite complex. If a patient is post-surgical, they have healed, the question of what goal of care they can have will now depend on how their post-surgical progress has been. Did they develop worsening pulmonary hypertension and now they are really palliative, or are they actually go back to work? I've been lucky to care for some patients who have actually gone back to work. They are very fit, they are physically active, and their heart indices are very good, despite walking around with one lung, and interestingly, one left lung at this point. I think on an individual basis, the goals of care can be set to include CPR for some of these people, and then of course those who are not doing very well can definitely be on a palliative pathway where it's DNR clearly from the beginning. And the same applies to people who undergo cardiac surgeries. They are high risk, and yet the most immediate post-operative period is fraught with so many complications that can result in cardiac arrest, including arrhythmias, including bleeding, especially hematomas, among other things. And so you have to have an algorithm, a pathway for providing a resuscitation, knowing that, for example, chest compression could cause, for example, they can cause injury directly to the heart, or can injure directly the lung that's underneath, among other things. Yeah. The other question is from Moses Ari. Maybe just since you guys already do some of the pneumonectomies, I would love to hear from my colleague, the cardiac anesthetist, also what your practice is. Dr. Cornelius, what would be your practice around CPR in the most immediate period for post pneumonectomy, post transplant patients?
I think like you said, Bruno's answer first of all is most times probably going to be a good answer to some of these situations. However, where you can't get the surgeon to immediately open to undo the wires, if that's what they did, then you may have to do some modification to how you perform the CPR. It's not contraindicated in pneumonectomies, but it requires some adaptation based on what pneumonectomy was done. So if a right pneumonectomy is done, the left lung doesn't extremely expand like the right lung in such a way that it will cause massive shifts of the myocardium away from the sternum. So the usual sternal compressions would probably work. However, if it is a right pneumonectomy, there is usually more shift towards the left side. So you may have to be a little bit more on the left parasternal border if it's a left pneumonectomy. Therefore, the right lung expands, so pushes the heart more towards the left side. So that's the general idea. However, the principles remain that you need to avoid overinflation and therefore using lower tidal volumes. And then there've been few case reports of this happening, and there have been success stories as well. It's not usually a good idea if you have to do CPR, because you may end up undoing the surgical repair done, and the bronchial stumps tend to be quite fragile as well. So the chances of survival at that point are really low. So the best option definitely would be to basically undo and do direct cardiac massage. But that may not be easy depending on how the sternum was closed. So that could actually be a challenge. Most instances in our setting, you're probably better off not doing CPR, because the consequences thereafter, in terms of severe hemodynamic instability, potential risks that you probably undid the bronchial, the stump, you have stump dehiscence or something like that, or rupture, is quite high. The odds are really stacked more against you than they are for survival. So it may be wise to just let it go, depending on what setting you're in. I'm not saying that's the usual goal, but in case you think you have the ability to provide more support for this patient after the cardiac arrest, then by all means. But you have to be very frank with the with the patient on the outcome, with the family on the outcomes for this, if you go ahead and do it. Most times you probably, so in some setting, they'll probably, if this happened, they will definitely resuscitate, and then they will probably just hook you up on ECMO and all those devices to keep you alive up until they fix whatever problem it is. But the chances in our setting for even getting that is very low. So yeah, it's a bad situation to be in. That's what I have to say.
Thank you. Okay, thank you very much. Yeah, so that is quite that's quite I guess that answers Lydia, especially in the immediate perioperative period. It is a lot of things stacked against you. All right, so next question here is Dr. Serenkuma, when the heart herniates and changes anatomical location, do we still place ECG leads on the same position, or are there is a new position, especially for the heart that move completely to the right side of the chest in the image you projected?
Thank you, Dr. Erasmus and Moses, for the question. So I think you're going to still mirror where your heart is, and you maintain if your heart has, for example, is herniated to the right. So you're going to mirror and then place your electrodes where you would have placed if the heart is still on the left position, so that you can pick like cardiac activity. So in other words, are you going to place your electrodes to the, of course, the right side where the heart is, but of course, putting into consideration how you would have placed them if the heart is on the left. So you do the same thing when it's on the right.
All right, thank you very much, Dr. Serunkuma. Yeah, we are doing badly for time now, and for further questions, kindly post on the chat so that Dr. Serunkuma can respond. I'd like to thank Dr. Serunkuma for that talk and also handling our questions and move us straight to the next speaker. We've heard from the anesthesiologist on how to prepare and manage these patients before, during, and after the surgeries that they need. Dr. Ronald Kawiye is a thoracic surgeon working with Mulago National Referral Hospital. He will take us through the surgical aspects of care of patients with end-stage lung disease. So over to you, Doctor. Kindly share your slides right away and start. Dr. Serunkuma, you can retire your slides so that Dr. Skobia can share.
Dr. Erasmus, I need some help. I don't know if you can stop sharing from that side. I'm trying to look for an option here.
Okay, just if you take your cursor up to the top. Okay.
Okay.
Perfect. Thank you. All right, Dr. Ronald.
Hello, thank you, Dr. Erasmus. I don't know if I'm on the same page. Am I seeing my screen?
No, we are not seeing your screen yet. It appears not, you haven't shared yet. So
okay.
Yeah.
Screen.
Just tap the green arrow at the bottom.
Okay. Am I there?
Not yet. So what I'll do, Doctor, let me
Yes.
share it from here.
Correct.
Since you shared it with me earlier.
All right.
All right. Should be visible now, Doctor.
Yes, true. I don't know how you will move. Anyway, thank you, Erasmus, and the entire team for the discussion. I'll just try and go through the brief highlights in the surgical care. So please go next slide. Dr. Erasmus, can you change the next slide, please? Okay, thank you very much. I think the previous discussants have already talked about the definition of end-stage lung disease as being irreversible indeed, in which there is inadequacy for adequate pulmonary function in terms of carbon dioxide excretion and supply of oxygen. And many of these patients eventually turn up with significant impairment in their functional outcomes. Next, please. Before we look at the different surgical option, I thought it was important to look at the possible causes of end-stage lung disease, because sometimes options are very varied. Although most times the end like heart lung transplant will eventually encompass both. So these are some of the commonest causes of lung disease, which puts patients into end stage levels requiring surgical options that we are going to talk about. Next, please. Okay, I just put this slide as one of the cases we had on our ward. This is a case of severe interstitial lung disease, which had, in addition, bilateral bolus lung disease. This patient was very, very, very dyspneic and was basically on oxygen, and even despite oxygen, was always like laboring all the time, 24 hours, 7 days a week. So this is a case which we had to help the patient by doing wedge as an option, wedge, and the wedge was done in a sequential. The approach we used in this case was wedge resection on the severe affected site, and then after a couple of months, then we did a second surgery. That's a wedge on the contralateral side, which was less affected by the bullet. And of course, the objective in this case was to provide more space by removing the dead space occupied by the bullet. Now, one important lesson to learn from this case was this patient postoperatively developed tension bolus state, developed tension in the bulla in the remaining lung, and we had to do a transthoracic bolus drainage. That's only we were able to pick out. So some of the learning point in cases like this one would be like when you are doing anesthesia, what pressures do you ventilate them with? And also being cautious that the remaining lung the bulla might undergo tension and compromise your parameters postoperatively. So that's one of the cases we had. So These are some of the surgical options which are available currently, like many centers right now. And these are coming from, say, a blood patient with end-stage lung disease, especially due to COPD. And these are based from some trial of national epizematus treatment trial with such a cumulative number in which they compared lung volume reduction surgery versus medical meaning these other drugs we use, bronchodilators and what. And criteria for lung volume reduction, basically based on high resolution CT to define which parts of the lungs are more emphysematous or which segments, or radionuclide lung scans. And options which are available, especially as regards this trial, were either segmentectomies, that is if the emphysema was restricted to particular segments in the lobe, or lobar resections. And of course, the approach was either VATS or by median sternotomy. And these are the benefits which these patients benefited from this kind of surgery for end-stage lung disease. Now, lung volume reduction surgery was able to provide improved exercise capacity, 6-minute walk distance, and the improvement in the percentage of predicted FEV1, and the level of dyspnea was also significantly improved, and the overall quality of life. However, the caveat based on this trial was a mortality rate of double-digit figures compared to those who were only treated with medical, especially in patients who had severe levels of COPD, as defined by FEV1 and DLC of less than 20%. And to note that there is no benefit in terms of exercise capacity or FEV1 parameters. So in terms of basing on this trial, the NET trial, if patient has severe COPD, then options for parenchymal resections do not offer any benefit, but instead increase risks of mortality. Now, other options which have also been available for lung volume reduction for lung could have been classified as non-surgical, and those are like endobronchial pathways. Commonly, they have used the one-way endobronchial valve, which allow expiration and prevent any more inspiration of such segments. And the objective here is to produce progressive atelectasis of such segments. Then other options which have been defined, self-activating coils, which when deployed in a particular segment, they assume a preformed shape, and then as they are kinking, the segments are also kinked, and then you have progressive atelectasis. Any residual air can be by absorption atelectasis. Then other options which have been defined are bronchoscopic thermal vapor aberration, which heats up and destroys emphysematous lung tissue, and of course through a laser approach. Then installation of biological adhesives, which have been which work by plugging off segmental bronchus, and then result into atelectasis of such emphysematous segments. Now, newer options have also been been developed where they have endobronchial bypass tract stenting, which encourages emptying of such air-trapped lung in emphysematous segment. Then in extreme cases, they have been defined like transthoracic transpleural ventilation using drainage catheters, which are like inserted like chest tubes, but they are special catheters and deployed into emphysematous tissue to allow decompression. So those are some of them. Next slide, please. Now we come to the forms of lung transplantation. The previous one were basically like salvage options. However, lung transplantation, especially in end-stage lung disease, as the previous speakers have mentioned before. Now, these are some of the categories which are currently available. The first is a living donor lobar lung transplantation. In this case, you have two donors in which each provides a lower lobe. The right lower lobe, and one provides a left lower lobe. And then these are transplanted into the recipient. Then the other category is single lung transplantation, of course, with organ harvested from other organ harvesting processes, and then bilateral, where I have dual lung transplantation. Remember, these first three are in exclusion of a lung heart transplant. Now, heart lung transplant is reserved for patients with severe dysfunction of the heart, at the same time the setting of end-stage lung disease. Classic example is Eisenmenger syndrome, where severe lung damage has caused right ventricular dysfunction, which cannot be repaired, without heart transplant. And however, with the current diagnosis, remember there are many diagnostics in these children, and this Eisenmenger syndrome is now a bit of not so common. So that indication remains standing. Now, I adapted this slide from International Society of Heart Lung Transplantation. It's a summary of a trend of how lung transplant has evolved over time. And this is data as far back 1987, roughly around when lung transplant was being started. And you realize that what is purple is bilateral, and then single is, green is a single lung transplant. What is very classical is that over time, the numbers of single lung transplant has remained nearly static, while bilateral lung transplant has gained increasing frequencies over time. Hard to explain this, but probably disease which affects and there are more organs to which there are more donor organs, with many places having donation programs, and two, disease resulting into lung transplantation eventually affect both lungs, so it's probably less likely to transplant one lung. Next slide. Okay, so this is adapted from the same data registry, and International Society of Heart Lung Transplantations, like a consortium of all centers which offer heart lung transplantation based in that's Europe, North America, and some few countries in like Asia, that's like China, Japan, and South Korea. So they subscribe to this program and submit all their data. And this slide basically shows the progressive decline of combined heart-lung transplantation over time. As you see, initially it was low, then it picked up probably in the 90s, but currently in the decline. And of course, this points to improved diagnostics and early treatment of disease conditions leading to requirements for transplantation of either heart or lung. So that's why combined heart-lung transplant is on decline, basing on ISHLT data. Next slide, please. Okay, so this is some of the criterion used for any patient to receive heart-lung transplant, based still on International Society for Heart-Lung Transplantation. And there should definitely be evidence of end-stage lung disease, as previously mentioned by prior speakers. And of course, there must be some minimum criteria. Basically, they are focusing on other comorbidities. Probability of death if no transplantation is done within 2 years, 2 years, and then high probability over 80% of surviving more than 90 days after lung transplantation. And then 5-year post-transplant survival of more than 80%. That should be in account that other comorbidities are probably absent or are controlled in such patients. And of course, many centers are recommending that it should not be more than 75 years, though some are restricting it to 65 years or below. Next, please. So donor selection, and remember these donors are patients who are going to provide lobes or lobes. If you are a living donor or cadaveric donor, you should have some minimum criteria. That's your age, and then no history of pulmonary disease, and then should have had normal serial radiographs prior, and then criteria of ability to maintain PaO2 of 300 millimeter at that support modes of ventilation. Since most of the donors are patients who have been on ventilation and then bronchoscopy should be negative, and then infectious risks should also be excluded. Now, the current matching is mainly for ABO compatibility, and that leaves some room for HLA incompatibility, which is the commonest cause of graft rejections in the post-transplant period. And then size matching, this is important in the techniques of lung transplantation. Sometimes with the donor is maybe so big compared to the recipient, then you might have size discrepancy, especially for the bronchus. And then you end up with size mismatch, which sometimes during the procedure increase the risk of bronchial stump dehiscence. So near size donor recipient improves recipient and donor bronchus matching, and then avoids additional techniques of like telescoping, which increases those risks. So these are some of the complications which might be able to watch out for postoperative hemorrhage from vascular anastomotic stumps, intercostal vessels, or any other thing. Then anastomotic complications can either be vesicular or bronchial. Now, bronchioles can be dehiscence, fistula, or stenosis, or malacia, in which they have like partial dynamic collapse. And there are newer texts to try and minimize this. One of these is reducing the length of the donor bronchus, such that the anastomosis is right at the upper lobe takeoff, reducing the distance. Then vascular anastomosis, noted as stenosis over time, kinking, especially if the donor is lengthy vessel, and after anastomosis, the anastomosis kinks up, cutting off blood supply. Then primary graft dysfunction, and then infection given the immunosuppression necessary for preventing graft rejections, and then pleural-space complications of chyle leaks, pneumothorax, air leaks, effusions, and possible other infections. Then we talked about rejection, which can be an acute or chronic occurring beyond 3 or 4 months. Next slide, please. So these are outcomes from the ISHL registry program outcomes for centers which have lung transplant programs. Now they are focusing on 3 parameters. One is the operative mortality, that is, and for transplant, given issue of acute rejection, is defined within 3 months following transplant. Another criteria is that mortality and then functional results. So basing on data from these registry programs, survival at 3 months for COPD patients who undergo lung transplant is roughly about 93%, while those with the idiopathic pulmonary hypertension is about 78%. Then at 12 months, that's 1 year, 86% of patients who have undergone lung transplant for COPD are alive at 1 year, while for those with interstitial idiopathic pulmonary fibrosis, 85%, while 87 patients with cystic fibrosis. Then looking at mortality at 1 year, mainly is due to non-cytomegaloviral infections and graft failure. So for those among people who issues about, for those who die beyond 1 year, 64% of patients who have undergone lung transplantation, and this is looking at bilateral lung transplantation. 64% will be alive by 3 years, another 53 at 5 years, and 31 at 10 years. So that shows you how successful the program is. And then these are main factors due to mortality in the late period of time. Then in terms of functional outcomes or results, many patients following transplant do not need oxygen to exercise after 8 weeks, 6 to 8 weeks of transplant. Then pulmonary function reach maximum predictable values within 3 to 6 months. And many patients, over 70% will have performance score of above 80% at 1 to 3 years. And some reports have been documented of even post-transplant patients engaging in extreme sporting events. However, remember, they should undergo structured exercise training post the program. It's part of the package. Next. Okay, so these are some of the factors that predict survival based on International Society for Lung Transplantation programs. And so among the ones, cardiac indices before exercise and after exercise, those who need mechanical ventilation in the immediate post-operative period are more likely to have less survival parameters post-transplant. Oxygen requirement post-transplant could predict ongoing rejection or other thing. Then age at transplant, the older you are, the less the likelihood of survival. And of course, with advancing age, you have more parameters of kidney dysfunction and other things. And then other things are like diagnosis, which at the start of the transplant. Next. Okay, I think I'll just skip this one. Previous speaker, Dr. Senokuma, has talked about it. The main who should not contraindicated, but I just left the slide in for future reference. Thank you very much. That's what I had in brief. Back to you, Erasmus.
Thank you very much, Doctor. Yeah, so this is, thank you so much for taking us to the surgical aspects. Do you have any questions, anyone in the audience? Yeah, no, so I don't see any questions here. But maybe just the experience from your from the service where you trained from. What was how was the arrangement for the emergency? I'm still bringing back the topic of CPR in these post-thoracotomy patients. What was exactly the precautionary arrangement to make sure that it happened in a timely way, in a safe way? And I'm referring especially to the aspect of thoracotomies, reopening a chest after. How was it organized in the service?
Okay, thank you, Erasmus. Best experience with CPL is when you've had a life, like a real case scenario. But like I would say for pneumonectomy, mainly they are done using thoracic approach. That's thoracotomy approach, and reopening of a thoracotomy is quick, I should say. Unlike sternotomy where I have to open sternal wires. Then the other thing I'd like to talk about is about the post-pneumonectomy pleural space management. Routinely, we do insert chest tubes, which we do clamp within like 24 to 48 hours. Now, reason why you leave a chest tube to free gravity and immediate post-op is you want to monitor bleeding, because you never know. If you're bleeding and you can't see, then you might, remember these are main PA or pulmonary vein stumps. So rapid bleeding, exsanguination. So you leave a chest tube drainage, and underwater seal drainage for the first 24 to 48 hours. Then after that, once I know immediate possible bleeding, then you can clamp. Now, the issue about mediastinal shift, that's cardiac herniation on the pneumonectomy side, is sometimes a late complication, because in acute setting, the pleural cavity gets filled up with fluid. In fact, within 7 days post-pneumonectomy, patients will have the whole hemithorax filled up with fluid. That fluid helps to balance the mediastinum and avoid that. But of course, some patients get herniation of the mediastinum into the pneumonectomy space, which can result into all these ambiguities. How do you do CPR, chest tube insertions later, all being precautionary undertaken.
All right, thank you.
Yeah.
Sure, thank you so much, Dr. Kabuye. Yeah, I see no more questions on the chat, and perhaps if any come through, kindly just look through the chat so I can give some responses there. So finally, I would like to invite our final speaker of the evening, Dr. Jack Churiahikayo. I'm sorry that we've delayed a little bit, but kindly bear with us. Dr. Jack is an internal medicine specialist. He completed his training in palliative care and served as part of the palliative care team at Makerere University before relocating to Lesotho. Currently, he is going to take us through the palliative care aspects in the care of the end-stage lung disease patients. So over to you, Doctor. Let's start right away.
Thank you, Dr. Erasmus, and good evening to you all.
Good evening to you. We can hear you well.
I just trying to share my slides. All right, I am hoping that the slides are shared now.
Yes, Doctor, we can hear you well, and we can see your slides as well.
Great. Thank you, Erasmus, for inviting me to this platform. I am certainly humbled for the invitation. And I currently have my practice in Lesotho, South Africa. And I'm glad that you invited me to share some insights around palliative care and chronic respiratory diseases. Interestingly, where I practice, we have a huge number of patients with chronic respiratory disease resulting from occupational lung disease because of, working in the mines for long periods of time. So we here, we suffer from, I think, similar challenges that we do suffer from in managing patients with chronic respiratory disease. I won't be long. I realize that I am the only one between us and the weekend. So I'll quickly a brief and give an insight to this. And I'm also glad that I think Liz Nyali, the head of the palliative care unit in Mulago, is on the chat. So I'm glad that he's doing that. Yeah, so this will be our presentation outline. We, first thing first, we look at definition and who are PC providers, because I think that's important for us to understand. And then we will go through the scope of diseases globally in lower middle income countries, the benefits of palliative care in chronic respiratory diseases, referral criteria of patients with chronic respiratory diseases for palliative care, and then we will definitely highlight the challenges that we experience, in terms of
Dr. Jack, there seems to be a bit. Okay. All right. I think we are set now. There's a bit of interference. Carry on, doctor.
And lastly, we will talk about a very key concept lately about refractory breathlessness, chronic breathlessness syndrome, which really is the final end-stage symptom, I guess, for many of these patients with chronic lung disease. So, in terms of definitions, I just captured the WHO definition. This was for 2020. We must remember that palliative care is an approach that improves the quality of life of patients and their families who are facing challenges associated with life-threatening illnesses, including physical, psychological, social, or spiritual. So that definition really reminds us of the idea that we need to remember the non-physical distresses and factors that could affect patient care. And here on the right, I just tried to put this table to highlight that, palliative providers can be primary or secondary. They could be, so they could be primary or secondary. Sorry about that. So the primary providers are usually the primary, healthcare workers who are looking after these patients. And this includes respiratory physicians, oncologists, and even general practitioners. So we like to have that paradigm of palliative care, simply because we know that, the largest primary palliative care needs can actually be served by the primary providers. And what do? They look at, symptom assessment and manage, the common symptoms that patients may have. And they also prepare the patient and family for advanced care planning. So this should be done concurrently with treating the primary disease. And then we have the secondary palliative care providers. And these are usually providers that have more training in palliative care. Sometimes this is called a specialist palliative care provider. And these really engage themselves in treating complex and refractory symptoms, and also escalate the conversation around psychosocial, spiritual, and concerns for the patients. and usually these then carry the care to end of life. So there is that sort of two classifications of palliative care provision. So we must remember that palliative care is the cornerstone in the management of patients with end-stage respiratory diseases, and it addresses a variety of needs that these patients have, including dyspnea, depression, cough, asthenia, sarcopenia, weight loss, anxiety, depression, pain, or even physical disabilities. And we must remember that, you know, these needs really intensify and culminate, into an end of life approach. And so we have to remember, to intensify care as the disease progresses. So it's important that PC palliative care for patients with chronic respiratory disease includes vital components such as social family support discussions about the goals of care and advanced care planning. And this is just a bit of statistics. The component of chronic respiratory diseases encompasses COPD, interstitial lung diseases, pneumoconiosis, pulmonary hypertension, among others. And I think these are just a few that are highlighted. And we must remember that in 2019, I think there are studies that showed that, CRDs contributed as the third leading cause of mortality. And in fact, 1 in 4 patients with chronic respiratory disease admitted to pulmonary wards will have palliative care needs. And it's important to remember that COPD is the most prevalent chronic disease among this category, and that there is a huge diversity in presentation with age, right from patients who are 30 to 79. And unfortunately, 80% of these patients live in low middle income countries. In terms of COPD itself, it's the 7th leading cause of poor health worldwide, and 90% of patients with COPD will demise under 70 years of age. And despite the high need for palliative care for these patients, only 14% of these patients receive the appropriate care. The epidemiology for interstitial lung diseases varies across countries, because remember, this is quite a broad heterogeneous group of diseases. And the global incidence has generally increased by 51% in the last 10 years. So what is the benefit of palliative care in chronic respiratory diseases? There's a lot of data to suggest a lot of benefits, and I've highlighted a few. That palliative care enhances management of symptoms, including dyspnea, depression, anxiety, and others. But also it improves functional capacity of these patients. There's a lot of improvement in patient outcomes, including better pain management, and we'll see some of the evidence in the subsequent slides. Palliative care also improves quality of life, and there is higher satisfaction with care for these patients. There is reduction in healthcare costs and utilization of expensive interventions for these patients. Palliative care reduces length of stay and avoids unnecessary admissions to critical care units. I think, palliative care gives the opportunity to have serious engagements in terms of the benefits and futility of care of patients with advanced lung disease. So most of the evidence that we have around chronic respiratory diseases actually emanated from lung cancer. This was a study that caused a little excitement. I think it was released in 2008. And in this study, it was a seminal RCT study looking at specialist palliative care versus standard oncology care within 8 weeks of diagnosis of metastatic non-small cell lung cancer. Of course, The intervention group first met with the specialist palliative care service for an average of 55 minutes, and then 6 weekly sessions with a member from the palliative multidisciplinary team, up to an average of 4 clinical encounters. And what this study showed was that there was a statistically and clinically significant improvement in quality of life, with a reduced proportion of patients with significant depressive symptoms. And I think the p-values were quite significant. But also there was a lot of excitement because I think for the first time, it was the first study that showed improved survival in the intervention group. There was also noted reduction in hospitalizations, emergency visits, total health care costs, reduced chemotherapy in the last 60 days prior to death, and then improved illness understanding, and of course, documentation of resuscitation preferences. So I guess this study gave us, a bigger scope in the benefits of palliative care among that patient population. And I think this evidence has been transplanted to patients with chronic respiratory disease. So, so what have been the lessons that we have learned from lung cancer? Again, this was a paper by Anna M. Walker and others, looking at early integrated palliative care for people with chronic respiratory diseases. And there were, about 6 or 7 lessons learned in that paper, looking at what we can draw from the studies around lung cancer. And they are highlighted as follows. So, challenging unmet symptoms occur in patients with chronic respiratory disease, just like lung cancer, and that there should be specialist palliative care, which is highly effective for people with both chronic lung diseases and lung cancer, and that palliative care should be offered early with a needs-based disease-directed care. And I think I will explain that because many times when primary physicians refer patients, they are basing on prognosis, they are basing on clinical parameters, they are basing on health system strains. But I think we need to remember that the referral should be based on the patient's needs. That's quite important. And then obviously new models of palliative care are urgently required in patients with chronic respiratory diseases. And then palliative care should be culturally sensitive and acceptable for each person involved. I think it's important that we know what exists in our context and be able to apply this information in a culturally sensitive way. And then obviously the model of palliative care must adapt to the evolving needs of the patients and the family of the carers. So the referral criteria, this is just a table, just comparing the needs-based criteria versus the disease-based or the health service utilization criteria. And I think what we have increasingly noticed is that the criteria for referral for palliative care should be really needs-based. And the needs are clearly straightforward. And if you go through this table carefully, we can easily identify these patients. For example, patients who have physical, emotional symptoms, poor symptom control, such as pain, breathlessness, weight loss, ataxia, a functional decline, if they are increasingly getting dependent and they can't perform the activities of daily living. If they've got psychosocial distresses and they need supportive counseling, spiritual or existential concerns around their illness. And then, of course, decision support, things like, advanced care planning, hospice referral, care of, coordination of, complicated, providers. All of these would actually be used as benchmarks for referrals. And obviously, don't forget that, we also look at, the carers, the family, the family will have needs regarding, the patient's illness. So these are also included in the needs-based criteria. This is in comparison to, on the right, what previously or what some primary physicians will use. For example, some people will say because this patient has multiple admissions or they have frequent admissions, we have nothing to do with it. Maybe we refer them to the palliative care unit. Some physicians will look at respiratory status, looking at, the severity of the COPD or the pulmonary function or pulmonary insufficiency. Others might look at advanced respiratory therapies just because the patient is on, invasive ventilation and so on and so forth. So I guess this question was a big debate a few years ago, and it has largely been settled. And I think this study, settled that question, looking at palliative care initiation in chronic obstructive pulmonary disease, prognosis-based, symptoms-based, or needs-based. And I think the carrying away from this paper was that there is none of the existing prognostic variables and multi-component indices that are reliable enough to exclusively predict poor survival in patients with COPD. So the decision to initiate palliative care should be rather based on the presence of refractory symptoms and patients' unmet needs and preferences. And I think, for me, this is one of the carry-away points, especially for primary palliative providers. We need to remember to look at the needs of the patient and the family vis-a-vis the disease state and severity of etc. What of the timing for referral of these patients into the palliative care service? I extracted this from the American Thoracic Society. This was a paper published last year, actually. And this, if you follow here, this is palliative care intensity, as disease progresses, and this is well-being with functional status. And this particular population included patients with lung cancer, pulmonary hypertension, COPD, and interstitial lung disease, as marked by the different colors. So in terms of when primary palliative care should be started, I think you can see that the red dot here shows that, at the time of diagnosis, patients with lung cancer, in fact, palliative care, should be studied fairly enough, fairly early enough. And then, this applies to patients with pulmonary hypertension and later on COPD, ILD. I think this just speaks to the fact that, COPD, ILD is catching up in terms of the early referral to palliative care, by the primary physicians. But if you notice that, this, care should actually improve over time. And you can see that secondary palliative care, I think this is the point that the specialist palliative care team is invited into the care, should actually be, not far down into the late stages of the disease, And I think the point is that, if the primary palliative care service is having challenges with patients' needs, this is the point to involve the specialist palliative care service so that they can support the care. So it's a collaborative approach and not to wait to invite the palliative care team at this point. I think we have moved away from this point where the palliative care service is involved at the point of death. I think we should be really thinking of starting the primary palliative care as early as possible and asking for support, collaborative support from the specialist palliative care service. So there still remains many challenges, especially in the lower middle income countries. And of course, we can't, it's probably well known that we have a huge disparity in terms of palliative care provisions for patients in, in high-income countries and versus low-income countries. This is such a huge difference. And there are studies that have shown that, in fact, there has been little or no increase in palliative care service in our region over the past 10 to 14 years. And which is unfortunate, because half of the global population residing in the lower middle income countries receive less than 1% of the required opioids to treat patients' symptoms. So you can see that, there's such a huge disparity where we have a lot more patients with quite advanced chronic respiratory disease, but with very little palliative care support. So the challenges are many in the lower middle income countries. Just notably, the scarcity of national policies. I think, at this point we should be thinking about, coming up with policies to address some of these challenges. Financial resources, lack of appropriate infrastructure and technology, the skilled workforce to manage these patients. So there's an issue of training and educating as many, and improving capacity for our clinicians. So those obviously limit us, and we still have great challenges in managing these patients. So I just wanted to say that, patients with chronic respiratory disease will have, a complex of symptoms. And some of those might be respiratory and others will be associated symptoms, just for us to remember. And I know throughout the sessions, we have talked about breathlessness, cough, hemoptysis, pleural effusions, airway obstruction, and eventual respiratory failure. But there's also a lot of associated symptoms, which we many times forget to address, such as pain, nausea, constipation, anorexia, muscle wasting, sleep disturbance, dry mouth, anxiety, depression, loneliness, isolation, and guilt. I think, we need to always remember that from the palliative care point of view, we need to address all of these symptoms wholesomely, and not just look at the respiratory symptoms that the patients have. In terms of prevalence of symptoms, I extracted this again from the American Thoracic Society. And this particular paper looked at unresolved symptoms in two population groups: patients with lung cancer, who are highlighted in yellow, and those with chronic lung disease highlighted in blue. It's important to note that among this patient population, in fact, dyspnea was more prominent in patients with chronic lung disease. All the other symptoms were in fact more prominent in terms of severity, symptom severity, in patients with lung cancer. So if you would ask me what is the critical symptom we should be treating as primary palliative care physicians, it's breathlessness, dyspnea, which is a very distressing symptom. And I think that's where I'm going to, talk about it in the following slide. So, as I said, chronic breathlessness is something that is talked about, more commonly now, the chronic breathlessness syndrome. And really it's quite an uncomfortable sensation, and patients will describe it as air hunger, chest tightness, increased respiratory effects, or fatigue. It's quite an uncomfortable symptom. Unfortunately, I think it's quite not addressed by many of the clinical teams, and patients really suffer a lot with these symptoms, and then end up having a lot of psychosocial related symptoms because of the uncontrolled dyspnea. So it's a big threat to survival. It triggers disease-related anxiety. It's just for us to remember that breathlessness does not always correlate with disease severity. So it's more of a subjective symptom. So we cannot relate it to the extent of pathology. And I guess sometimes that, as clinicians, that's what we do. by looking at the X-ray and looking at the patient and saying, the two are not matching. So I guess we have to remember that it's a highly subjective symptom. There's a cognitive and affective dimension. So we talk about the multidimensional mode of dyspnea. And unfortunately, we know a lot about pain and pain control, but not for dyspnea, very unfortunately. This is just a schema highlighting dyspnea and the factors that influence dyspnea. We've got to remember that the breathlessness center is actually, in the brainstem, but there are many components that drive into that. And that, there are many psychological, social factors that might drive into this center and therefore cause more breathlessness, right? So this is just a schema to show that mood, cognition, context, all of them are quite related in terms of driving the severity of breathlessness. And so when we treat, we've got to treat the triggers, but we also have to remember to appropriately treat the symptom. This was a paper by Hudson and others looking at unintegrated palliative and respiratory care service for patients with advanced disease and respiratory breathlessness. It was an RCT, single blind, enrolled consecutive adults with refractory breathlessness and advanced disease from 3 large teaching hospitals. These came through general practitioners in in hospitals in South London. These patients were randomly allocated to receive either the breathlessness support service. This was, quite a package, vis-a-vis the usual care. So what did this package include? Short-term single point of access service, integrating palliative care, respiratory medicine, physiotherapy, and occupational therapy. And the research interviewers were masked as to which patients were in the treatment group. The primary outcome of the study was to look at patient-reported breathlessness mastery, which is really a quality of life domain, in patients with chronic respiratory disease. And they used a questionnaire for that at 6 weeks. And of course, all the analyses were by intention to treat and survival as safety endpoints. So this was a trial protocol looking at a total of 260 patients who were referred. They excluded quite a number of patients, 105 underwent baseline interview and subsequently were randomly assigned, 53 assigned to the breathlessness support service and 52 to the usual care. And there were some that dropped off along the way. The intervention group supported 2 were interviewed at 6 weeks and eventually 42 analyzed. And for the usual care, 40 were analyzed. This is just, a lot of questionnaires that were used to assess, the outcomes, the quality of life and healthcare factors. So what did the results show? At 6 weeks, there was a completion rate of 78% and mastery in the intervention group versus the control. Was quite interesting. It was quite clear that the numbers are telling there's a mean difference of 0.58, with a significant p-value. Survival rate from randomization to 6 months was better in the intervention group versus the control group. Obviously, the survival differences were significant for patients with chronic obstructive pulmonary disease and ILD, but the patients with cancer did not benefit. So what does this paper tell us? That in fact, if we have palliative care interventions to address symptoms such as refractory breathlessness, that there is always a benefit in many things, in terms of how the patients feel about their symptoms, but also in survival, which is exciting because, as you know, previously in palliative care, we hardly talked about the question of survival. And now there's a lot of evidence that is coming through that actually excites us, that by controlling patients' symptoms better, then we are able to demonstrate that these patients live a better quality of life. And in fact, there is benefit and also the survival benefit for these patients. In terms of approach to refractory breathlessness, you know, this is the protocol that we have in the palliative care service for patients in the ICU and those on the wards. But primarily, there is two arms to it. Remember, there is always the non-pharmacological and the pharmacological. And the non-pharmacological things are not difficult to do, but they make a huge difference for patients when they are done. Things like positioning, you know, relaxation techniques, you know, controlling the air in the room, cooling the patient's face, using a cloth to, you know, to clean up the patient. Those, and I think there's evidence that those non-pharmacological interventions there's such a big difference. When it comes to the pharmacological ones, you know, we largely use opioids to control breathlessness, and there's a lot of evidence of how opioids, you know, break the cycle of breathlessness. I think that's another story. But you know, morphine, fentanyl are the drugs that we use in those doses. And because breathlessness is associated with anxiety, agitation, there's also a use for benzodiazepine. So in most protocols globally, I think what will change is the dose and the availability of the appropriate drugs. But, you know, the class of the drugs is opioids, benzodiazepines in the doses highlighted. Just to note that you know, for patients who are on the wards, the doses are a little bit different because we are not using infusion pumps for these patients. So we are using 4-hourly doses of morphine and monitoring the symptom. And I think there's a difference in how the medications are given. In patients who have significant respiratory distress, the game changes a little bit. Please note that the doses are a bit higher compared to those given to patients with mild and moderate respiratory distress syndrome. So I think I'll leave this protocol here for members to go through and be covered with the appropriate doses that are applied. I just put in this slide just to highlight the chronic breathlessness syndrome. But clearly there are patients that even when we treat, you know, the symptom just persists. The breathlessness persists despite optimal treatment of underlying pathophysiology, and it results in disability for the patient. So that's typically sort of the worst state that patients will go to, that everything we do pharmacologically and non-pharmacologically, the patients don't respond. And I think in this chart here, it's just important to remember that this syndrome can be contributed to by many disease states and not just chronic respiratory diseases. I also had the previous presenters talk about, you know, the association of lung, heart problems in patients with chronic respiratory disease. But, you know, increasingly, effectively, you know, you have patients that that whatever you do are going to remain with the symptom. And I think this is when we think they have this syndrome, and this is when we think, okay, let's now escalate advanced care planning. Let's begin to talk to the patient and the family. Let's begin to think ahead of the time. Just also to remember that there's a stepwise approach to breathlessness, from step 1 to step 4, where step 1 is mainly non-pharmacological, and step 2, 3, and 4 includes the pharmacological aspects, and control symptoms. This slide here is just not to forget the other symptoms that patients might have: cough, weight loss, sleep disturbance. And if you realize that the approach to most of these symptoms is actually non-pharmacological. So you've got nutritional support for weight loss, cognitive behavioral therapy, sleep hygiene strategies for sleep disturbance, psychosocial support for patients with depression, anxiety, and psychosocial distress. So I think we just need to have, our understanding that there's a lot of non-pharmacological interventions that create a huge difference for our patients. I'll just end off with this slide here, talking about building a primary palliative care team. I think, it's important that the pulmonary service begins to think of, how they can address patients and patients' needs at the primary level, because the specialist palliative care providers are never enough, unfortunately. So I think, it's important just to use this framework, and have each provider do a little more in terms of palliative care. Like the nurses who can help with medical triage support, social workers, if they are available, who can then begin to approach psychosocial challenges of the patients. The physiotherapists who are important for exercise training and pulmonary rehabilitation, chaplains who will address spiritual needs of the patients, which we hardly think about. And then at step 2, you need to now think about symptom management. Do we have appropriate opioids to manage patients with refractory dyspnea? Do we have alternative opioids? I think the story of opioids has been very, very complicated in our setting because of the limitation of use. And I think we still need to address challenges like that. Yes, and then obviously down the line, depression and anxiety, we need to also include clinical psychologists. We need to talk about important things in advanced care and ask very difficult questions. I think these are things that many clinicians will want to avoid, but in palliative care, this is the gist of the conversations when it comes to refractory symptoms. And then if you have something set up to address the needs across the physical, psychosocial, spiritual, then I think that's sufficient, for palliative care. Right. So these are my references. I'm really sorry that I overshot, but these are my insights around this session. Thank you very much.
Thank you very much, Dr. Jack. This is quite rich. And I'm sure there'll be so many people in the inbox asking for slides and other cues. To start with, what do you think? I hold this notion that palliative care should be part of the care of every patient admitted to ICU, regardless of their prognosis, regardless of their condition.
Yeah, it's a great question, and I think a relevant question. The thing is that many patients, I think our observation in seeing many of these patients in the ICU is that they've got needs that we largely unexplored. They will have needs, especially the patient and the family. They will have needs, but simply because we don't engage them enough. And I think it's always good as a critical care service or ICU to spend time with the family and just try to understand, what is through their minds regarding the disease of their relative. And I think if we did that, then we realize that we can solve a number of problems. Notably, things to do with futile treatments. Most of the times when we communicate with these patients and do advanced care planning, then we are asking, questions around resuscitations, questions around, should we increase any interventions? Should we, just give more medications? I think what we actually get is that when we do explain and have candid conversations with the family, many don't want to get there. They don't want to see their patients and loved ones in a state of suffering. And I think at that point, we have to be clear and on the same page. So it would be ideal that, we involve the palliative care service so that some of these non-physical things are solved for and relative to address them.
Thank you. One more question, Doctor. What is your take on euthanasia?
Yeah, great. Yeah, so I mean, this again is, I think, a very relevant question, and it's been asked, so many times. I think the truth about euthanasia is that when patients say, doctor, please give me a pill, I want to rest. Actually, what they are saying is that I am suffering too much that I'm better off dead. So it's really an expression of a lot of unmet and uncontrolled symptoms. So because with good palliative care and with good symptom control and with good quality of life, there are very few people who would ask for euthanasia. So our experience is that whenever you have a patient, going the route of the discussion of euthanasia, 9 out of 10 times is that they are suffering too much and they think in their minds they are better off dead. It's just like a patient who is depressed and thinks that, there is no options left, and so they are better off dead by taking their life. It's just the same thing. So I think it's important that those patients are given opportunity to express, and you realize that they will have a lot of psychosocial and spiritual concerns around their care.
Thank you very much, Doctor. That is excellent. I guess also directly to Dr. Opio, who asked that question. Currently, euthanasia is not yet legal in our setting, but yes, in some territories, it has been introduced in different names, things like medical assistance in dying, MAID, or physician assistance in dying, that's paid. Some people call it doctor assistance in suicide. They try to avoid certain words, but essentially, yes, there are patients who might qualify. They have got terminal disease, they're suffering a lot, and there's really no hope that there's a cure or alleviation of their symptoms. And so, mercy killing is an option out there. But even in the countries where it is available, it's not universal, meaning that every hospital can screen and refer you for MAID, but only a few facilities might want to take the responsibility of offering it. So currently in our setting, we don't offer it. So it really comes down to taking care of a patient very well, and like Dr. Jack just mentioned, paying a close attention to the unmet needs of a patient who's crying out for such help. Yeah. So thank you so much, Dr. Jack.
Dr. Erasmus, can I just also mention that there is one concept that sometimes might be confused with euthanasia, where the palliative care service might withdraw certain interventions that are futile. Now, I think previously there's been sort of conflating these two, two aspects. I think there are times when, if the treatments are futile, the palliative care service, in conversation with patient and family, might withdraw those interventions. Now, that's not euthanasia, because as you said, euthanasia is deliberate physician intervention to end life. So there is what we call letting nature take its course, and that shouldn't be confused with euthanasia. I just wanted to make that clear.
Sure. Excellent. Thank you so much. All right, Doctor. It's now 8. I would like to bring this to a close, everyone. So thank you so much to our presenters for the day. Dr. Paul Maderu, who took us through the radiology aspects, followed by Dr. Bruno, who ably discussed the care of patients with end-stage lung disease. And then Dr. Ronald Kabuye, thoracic surgeon, who took us through the surgical aspects of care of patients with chronic lung disease. And then finally, we've had Dr. Jack take us through the care of patients whom we cannot save, but who can at least ensure they don't suffer. And probably this is going to be what we do a lot more in our setting, whether we provide a surgical intervention or not. The quality of life and outcomes of this patient are usually very great. So thank you so much to our presenters for that day. And that really brings us to the end of our talk today. So this has been Pulmonary Madness, episode 13, actually, at the end of the road. And in this, we've understood the difficult conversations, the expensive care options that await people whose lungs have reached a point where they don't function anymore. Usually, these are guys with very poor substrate, and so the surgical options are also very limited. But there are some innovative options out there, and hopefully transplant will one day be in our setting. However, it remains quite a dream and quite a difficult journey ahead, given the resources we don't even have for the low-hanging fruit so far. Palliative care is something that's very key for us to appreciate, to understand, and to deploy to all our patients. This has been quite rich. Thank you very much to our presenters. Thank you to the audience. And thank you to you guys for always turning up. This is essentially the end of Pulmonary Madness. It's been 13 episodes, and we've enjoyed ourselves covering lung pathology, lung physiology in the ICU. And so we will take a slight break, and then we shall return with a new theme to our Friday rounds. So thank you everyone for joining us today, and I would like to wish you a happy weekend, a happy Easter until we meet. Thank you. Bye-bye.